Thank you so much. Dumelang. This is greetings from Botswana. I'm going to take you through what we have done so far in Botswana. I just want you to know that Botswana is not perfect, but we are trying our best. Botswana is located in Southern Africa with a population of around 2.4 million, and it has a generalized epidemic with prevalence of 18.5% among the general population, and people living with HIV, they are around 374,000. And amongst pregnant women, we are around 22%. It's very high. We are among the highest in Africa. The goal of eMTCT is to eliminate new pediatric HIV infection, improve maternal, newborn, and child survival and health in the context of HIV. And for Botswana, we are saying our main objective is to reduce mother-to-child transmission to less than 1%. That's an ambitious target. What is it that we are doing? We are with testing for pregnant women. We are really doing a lot of testing, and the purpose of this is to try and identify seroconversion as early as possible. So at ANC registration, we do initial testing. 3 months, every 3 months, we do retesting until labor and delivery. At labor, if the last test result is more than 4 weeks, we do the testing again. And then the retesting again for all those who are HIV negative is done again at PNC, postnatal care. Then the other retesting is done during breastfeeding every 3 months until end of breastfeeding. For infants, we do DNA PCR 4 to 6 weeks. For those who test positive, they are initiated on treatment, but we collect specimen again for confirmatory, but we don't wait for the results. Then all those who are HIV negative are retested again. And for those who are breastfeeding, they are retested 6 weeks after the last breast milk. And then our final diagnosis is done 18 to 24 months for all babies who tested negative. For infant feeding, we have 2 options. We have breastfeeding. We encourage breastfeeding for those who are virally suppressed. And for Botswana, when we say virally suppressed, we mean less than 400 copies, not 1,000, as per WHO. We've set ourselves an ambitious target. We are saying less than 400 copies. Then for those who are not eligible for breastfeeding, we provide infant formula. Infant formula is provided for free to women who are HIV positive and cannot breastfeed. And the formula is provided in our facilities. Yeah, for care support, we provide universal access to treatment, and almost all our facilities are providing ART either on site or as an outreach. And we also train nurses and midwives that are the ones who are doing prescribing and dispensing for ARVs, so that we optimize our access to treatment. Then we also try to integrate our services as much as possible. For HIV-infected children, they are initiated on treatment as soon as they are identified to be HIV positive. This is the protocol trends that we initiated right from inception. We started with option B plus, which is AZT only. And by then, during the inception of the program, that was what was available for us. And for infants, we give AZT for 4 weeks and then a third dose of nevirapine after delivery. And we moved on to option B, which was triple ARV prophylaxis. Then the protocol for infants remained the same. Then in 2015, we moved to option B plus, that's treat all for pregnant women. And with the treat all for pregnant women, we divided our protocol for infants into 2 options, either high risk or low risk. For high risk, for low risk, we are giving AZT and a third dose of nevirapine. And for high risk mothers, we consider high risk mothers as those who presented late for treatment or they are not virally suppressed. So we decided to give their infants AZT, 3TC, and nevirapine immediately after delivery. Then in 2016, we started treat for all for the general population. And this also, all these protocol changes, as you can see, they really had an impact in the reduction of mother-to-child transmission. What are the key milestones that we put in place as we were on path to elimination? At inception, our parliament prioritized PMTCT, and PMTCT has been prioritized in my country since inception. And Botswana was the first African country to implement a national PMTCT program, which started in 1999. Then immediately after that, we introduced ART program. We were also one of the first countries to provide ART to the whole population. And by then, we were using a cut-off point of CD4 of less than 200 and WHO staging 3 and 4. Then this included even the pregnant women. It also had an impact in increasing access to treatment to pregnant women. Then we also introduced a cadre called lay counselors. This was a game changer for our program because the lay counselors were looking at testing pregnant women, and we had access to testing. Our coverage improved, and it was really a game changer for us. Then we introduced the routine HIV testing in 2005, and this also had an impact in our testing coverage because it reduced the time spent in pre-test counseling that we were doing before introduction of routine HIV testing. The other initiative that was in place was still in 2005, whereby we introduced PCR testing using dried blood spot. And we were the first African country to implement it as within a national program. This really assisted us to test our babies early, because before that, we were testing all babies at 18 months because we could not use rapid tests on babies who were less than 18 months. So in 2010 to 2011, we revised our curriculum and guidelines, whereby we were including all the protocols. Then we were capacitating our health workers so that they know what they are supposed to do. The other milestone that we initiated was program evaluation. In 2015, we conducted our first program evaluation, And this was the purpose of assessing progress, identifying program problems and gaps, and also identify facilitating factors, good practices, and then so that we can improve our service delivery. Then we also decentralized the PCR testing. Initially, when we introduced PCR, it was done in 2 labs in our 2 main cities. Then we decentralized the PCR so that we improve access to testing. Then we did what we call routine data quality assessment in 2018. And the purpose of our RDQA was to assess, monitor the quality of reported data, then so that we can develop action plan to address challenges to ensure data is accurate, reliable, and of integrity. And we did that. After that, we identified our gaps and we tried our best to work on those gaps. Then we also introduced what we call data audits for HIV positive infants. What we did was that as soon as the baby tests positive, we took that baby through the data audit process. And this was in small scale at program level, but we really wanted to know what are the possible factors related to HIV transmission. And this really helped us to make strategic plans to close those gaps. And since 2017, every year we are doing our data audits for HIV positive infants. We have a very small number of babies who are positive, so we are able to subject them through the data audit process. And then the other thing that we did to try and make our data robust, we collected the data from private practices. Initially, our private doctors were not reporting. Then we went around all the private hospitals in Botswana to ensure that they are giving us a report every month. And then there was the use of the HIS2 reporting system, which we have not been using. And during, with the initiation of the HIS2, the PMTCT program intensified the reporting, and we became the only program in the Ministry of Health that we recorded 100% reporting rate. All our 627 facilities that are reporting for PMTCT, they gave us the report throughout the year. So we really managed to strengthen our data capturing, and we were doing a lot of follow-ups to ensure that all facilities are reporting. Then we started even in 2019, we did what we call data verification. It was a very hectic, and it was really hectic because we had to go around all our districts. There are 27. We sampled our facilities, we collected the data from the data collection tool so that we can look at our data and compare it with the reported data. What is in the tools, is it the same as what is in the HIS? We were just verifying our data. Then we started the provision of free ARVs to non-citizens in 2019. These are some of the milestones. Oh. Oh. Okay, these are the milestones in a graphical form. It's only that it's too long, so you cannot see how it went up. But this is exactly what I was talking about, but it's just giving you numbers to show that after initiating this, this is what happened. As you can see, we started from as low as 27% program uptake and 49% testing. And right now we are at 98% for both. This is program data, not spectrum estimate. And the program data is the one that we are using to see whether all women that that comes to our facilities, are we giving them services? Okay, before the validation process, we subjected our data into an analysis program. We really looked at our data to see whether we qualify for validation. And we were looking at the data to see whether we fall under pre-elimination, elimination. Then the data showed us that we are at pre-elimination and we qualify for silver. And then we decided to grab the bull by the horn. Okay, now going into the validation process, what is it that we did? We started by establishing a national validation committee. And this is a group of experts from different fields that were appointed by the permanent secretary in the Ministry of Health. And then we did our scheduling of the meetings, and we went through all that schedule. And the first thing that we did before starting the validation process, we did what is called the self-assessment. Because with self-assessment, it can help you to see whether you need to do something before going into the actual validation. And this has been our timelines for the process. We started November 2020. We were supposed to complete our validation process in February 2021, but unfortunately we could not finish. We had to do some of the verifications and the validations, and we completed the process around April, May. And that's when we submitted our report to the Regional Validation Committee. I don't know what is happening with this. Okay, what is it that we've learned in our throughout the process of national validation? We learned that representation of our National Validation Committee is very critical. We have to ensure that you include everybody who is supposed to be included, and also including the civil society, the human rights groups, and everybody else. Consultation and keeping your leadership in loop is really, really critical, because you really need their support. You have to be flexible and ready to accept results, because it's not an easy process. And then pre-assessment is key, because you really need to gauge yourself. How ready are you before you can go into the validation process? Political support is critical. Data quality is really, really important. You have to make sure that your data is of quality. Then you need to understand this is a very intensive process. It requires a lot of technical and financial support. Okay, what are the lessons from Botswana? Strong political will. The eMTCT is one of the president's commitment. Right now, he wants gold, and he's very serious about it. Government funding for the program ensures sustainability. We do not have to depend on donors, because when they pull out, you don't know what you are going to do. If you are using your government funding, or most of the funding that you have is from the government, you can be able to sustain this process, the program. Quick response to new evidence, like I've shown you the trend of our protocol. As soon as something new and better comes in place, we run with it. Investment in capacity building of health workers is really, really important. Make sure that your healthcare workers know what they are supposed to do. It's really, really important. With us, every protocols that come in place, we train our healthcare workers. We use the focal person model in Botswana, whereby each and every district has a focal person. And the focal person is the coordinator of PMTCT at district level. And we are working very, very well with the focal person. We know, they really know, they are very motivated and they really know what they are doing. And we are funding them right from the program. Each and every year, they make their plans, they submit to the national office, we fund them from the program vote because our program is well funded, to be honest. Yes, please. Now, in conclusion, is eMTCT of HIV possible for Botswana? Well, our main challenge in Botswana is the high prevalence rate. As we know that we have a very good ARV program that is really working. And our women are healthy and they live long. So we don't expect the prevalence rate to go down anytime soon. And the case rate, which is one of the critical, very critical criteria for validation, is the case rate. So with the case rate, with the high prevalence, which is used to calculate the case rate, and if it's high, obviously you are going to have a high case rate, regardless of whether you qualify for everything else. The problem for Botswana is the case rate. So what are the opportunities for Botswana? Effective and efficient program, ARV program. The country is on right path to reaching epidemic control, because with the Spectrum 2022 and our preliminary results from BIOS, Botswana HIV Impact Survey, we have reached the 95, 95, 95, as you can see. We are at 95, 97.9, and 98. And this is also the same as the Spectrum 2022. HIV prevalence is high, but it's slowly going down. We have an effective PMTCT program, and we are now shifting to our focus to young women, key populations, so that we can reduce incident infection as much as possible into the childbearing age, so that when the others move out of the childbearing age, others that are coming in, at least their transmission or their infection is lower than those. That's the only way, because right now we have very high prevalence rate and it's going to be high for some time. We are continuing with treatment optimization. Then in conclusion, yes, I think it's possible, it's feasible, even though it's going to take long, especially for high burden countries like Botswana. And we've set ourselves again another ambitious target. We want to go for gold. And for Africa, I've seen that with African countries, we do have African countries that have low MTCT rate. They have a chance. All you need to do is to try and close your leaking taps and you will be there. I believe we can eliminate even in Africa. Let's just tweak our data, look at what we can do and perfect ourselves. We will be there. Thank you so much. And this is my ambitious and very passionate team of focal persons together with the national level in one of their review meetings. Thank you so much.